Hey everyone, welcome to our latest innovation of Your Amigos podcast. This is Your Amigos Live. It's a debate series that we're going to try out, sort of short, sweet debates to the point. We have Matt Galsky here today and also Tom Powles, of course, to take either side of the debate of adjuvant nivolumab and bladder cancer. As you may know, the FDA has given a broad label to adjuvant nivo, not restricted by PD-L1 status, whereas EMA has restricted to PD-L1 positive patients. So we're going to sort of take each side of that and break it down. Matt, if you want to start off, I'll give you 2 minutes for your initial sort of argument on why adjuvant nivo should be given to a broad population, and take 5 seconds just to introduce yourself real briefly first.
I'm Matt Galsky. I'm a medical oncologist at the Icahn School of Medicine at Mount Sinai, where I focus on bladder cancer.
Go ahead, and I got 2 minutes to make your argument.
Okay, so the Checkmate 274 study, large randomized phase 3 study seeking to explore the benefit of adjuvant nivolumab in patients with urothelial cancer at high risk after definitive surgery. And that included patients who had neoadjuvant chemotherapy and had residual disease, or patients who didn't have neoadjuvant chemotherapy but were cisplatin ineligible. The co-primary endpoint was disease-free survival in the all-comer population and in the population of patients with quote-unquote high PD-L1 expression. That was defined in this study using the 28-8 antibody and staining tumor cells at a level of greater than or equal to 1% was a positive PD-L1 test. The all-comer population showed an improvement in DFS with a hazard ratio of 0.7, and the PD-L1 subset demonstrated an improvement in DFS with a hazard ratio of 0.55. Notably, the patients with TC less than 1% had a hazard ratio of 0.82, and the 95% confidence interval was 0.63 to 1.06. We did retrospective analysis presented at ASCO GU, where we looked at CPS, combined positive score. So not only looking at tumor cell scoring, but immune cell scoring as well. That's the assay that commonly comes back in pathology labs these days. And interestingly, if you look at a CPS of greater than or equal to 1, 88.6% of patients had a CPS greater than or equal to 1, and the hazard ratio for that population was 0.62. In patients with TC less than or equal to 1, but CPS greater than or equal to 1, so the CPS high population that was TC low had a hazard ratio of 0.73. So there's a very small subset of patients, probably definable by PD-L1 expression, that might not derive a lot of benefit, but the vast majority of patients do. We can't select the patients who don't potentially benefit well enough to not allow patients to potentially experience the benefits of adjuvant nivolumab at this time.
Perfectly timed. That was 2 minutes. All right, Tom, your rebuttal.
So the first thing is, one swallow does not make a summer. And unfortunately, we've had negative trials with atezolizumab for progression-free survival. But importantly, we've had a negative overall survival for atezolizumab in this setting previously. We've not yet seen any OS data for nivolumab. And that means that all we're doing at the moment is we're talking about disease-free survival, and we know there's an imperfect relationship between DFS and OS. So the first thing is this: whatever we do now, there's a leap of faith. That's the first thing to say. The second thing is, I think Matt articulated very nicely the confusion that we have around the biomarker. And I know there's a lot of uncertainty around this, but we also need to remember a second important thing. We've seen chemotherapy before, and the chemotherapy adjuvant data, the DFS was coming in the 0.4s, the late 0.4s, but there was no significant overall survival benefit. So to go down an ITT route at this stage, driven by a hazard ratio of 0.7, is very brave, because it may not derive an OS benefit based on previous data and indeed on chemotherapy type data. So it's a lot of uncertainty, firstly. And secondly, remember, whatever happens, we know many of these patients won't relapse. And therefore, inevitably, we're over-treating a large group of patients with no proven survival benefit. And under those circumstances, we're taking risk without certain gain. And in the adjuvant setting, that's very different from the metastatic setting, where the risk-benefit ratio favors treatment rather than caution. I put it to you at this point, in the adjuvant bladder cancer setting before, we have not yet seen consistent enough data to move forward. And therefore, either not giving the drug or indeed pursuing the PD-L1 biomarker positive population where the hazard ratio was in the 0.5s, let's be absolutely sure it should be the predefined population, is more sensible than the risky approach where we give it to everyone 0.7.
All right, your time's up. Matt, your 30-second rebuttal to that, and then Tom, I'll give you the final 30.
So I agree, we ultimately need to wait for OS. That is the definitive endpoint in this setting. I will say, though, that I think we're holding immune checkpoint blockade to a higher standard than chemotherapy. Chemotherapy in this setting is arguably considered a standard of care supported by most practice guidelines. So why should we hold immune checkpoint blockade with arguably a better tolerability profile than chemotherapy to a higher standard, pending the survival data?
Tom, last word.
I am worried that we may be overtreating large groups of patients that don't need therapy at this point. I think there's a lot of uncertainty around the PD-L1 biomarker. And actually, I quite like the ctDNA data. The ctDNA data is the only data, although exploratory, that currently has a survival type signal in it. I also want to make it really clear that if we are going to use a biomarker, my preference would be to use the one that was defined, the TC biomarker in the clinical trial, because I think the exploratory biomarker is too much of an exploratory approach right now.
All right, thank you both. Sounds like waiting for survival data and wanting a better biomarker, and in the meantime, sort of imperfect application of this drug that's very much provider driven by bias. Thank you both. Appreciate it.
Thank you.
Thank you.